Welcome you all in this meeting, and from the LSU, I would like to thank you all for coming for the first AIOCMTC conference. We are already getting late, so I request Dr. Shamya to present his talk on dry eye and cataract surgery.
And I'll request all speakers to stick within their allotted time of 7 minutes. Thank you.
Thank you, sir, and a very good afternoon to everybody. Today we are going to be discussing about management of dry eye in the cataract patient, and I'm sure all of us know how difficult it is to manage these patients sometimes, and sometimes it's more difficult to handle our post-op complaints of dry eye than it was to handle the cataract itself. So 25% of patients who visit ophthalmic clinics report symptoms of dry eye in some form or the other. So it's actually a very important condition for us as ophthalmologists and not only as cataract surgeons. And dry eye, we know, affects both quality of vision and quality of life. And it affects not only the quality of life of the patient, but also for us as doctors, because if they're not happy, they're going to keep coming back with the same complaints. Depending on the age, the incidence of dry eye after cataract surgery increases. So which means after a certain age, there's a very high incidence of dry eye in our patients after cataract surgery. And with the increasing population, we all know that we are going to be facing a lot of patients in the elderly age group who are definitely going to be bothered by very significant dry eye, and it is up to us to be prepared for this. So dry eye patient factors may include older age, female gender, and now very importantly digital device use, which is not only important in children or teenagers anymore, but across all age groups, because all of our elderly population is so dependent on our mobiles and TVs for passing their time, because they don't have people to talk to anymore. So all of us are addicted to digital devices, so it's a very, very important thing to address as doctors. Environmental factors can include air pollution, allergens, and low humidity as well. A very important thing for us to be aware of is medications that the patient is using. We are quite tuned to topical glaucoma medications that may be causing dry eye, but sometimes it may be necessary to go back and find out the systemic medication the patient is on as well. So why is it really important to us? What can dry eye do to us, our patients, after cataract surgery? So preoperatively, just like Dr. Jeevan Titi, I'll just discuss, it can cause errors in placido-based topography, and it can cause increased higher order aberrations. So placido-based topography and keratometry is very important for us, especially in toric IOLs, where the axis we decide for placement of the IOL can be influenced by our biometry errors. And of course, we know that sometimes increased aberrations may be an important factor in deciding whether the patient is suitable for multifocal IOL or not, but most importantly, to make sure the patient is treated before cataract surgery so that he is not unhappy after a premium IOL. And potential concerns after surgery can be delayed wound healing. A lot of studies have been done to show the importance of using lubricants after cataract surgery and the effect the tear film can have on wound healing after surgery. So potentially infections, delayed rehabilitation. We are all very attuned to foreign body sensation that the patient complains of, and there is definitely a decrease in the quality of vision, which is very important for us to be sensitive about. So what happens in normal eyes, even without dry eye, after a blink, there is serial degradation in our tear film, which can affect our quality of vision. So you can imagine how bad it is in a patient with severe dry eye. The tear film is going to degrade, and sometimes that even before a blink, even before the patient's normal blink, the tear film may degrade enough to affect the patient's quality of vision. So this is a small experiment sort of thing I did when I was in Narayan Netralaya. So we took a normal patient, we put him in air conditioning, and we checked his, we did a dry eye scan on him, and then the same thing we repeated after a simple drop of lubricant. So like you can see the point spread function, how much that dot is spreading is worse just by sitting in air conditioning. And after a drop of lubricant, it improves. So this is the difference the tear film can make to our quality of vision. So there are various ways in which dry eye can be precipitated after surgery. In cataract surgery itself, it may be because of transient spasm of the lacrimal gland due to the peribulbar block. It may be influenced and worsened by corneal incisions. Eye drops, we know, with preservatives will definitely worsen dry eye. It in turn leads to inflammation, in turn to increased osmolarity of tears, and in turn it can reduce pH, causing a lot of discomfort to the patient. It's very important to deal with these patients in a systematic manner, so to go through triaging, analyzing risk factors, and then maybe classifying the patient's condition and treating it. An attempt should be made to classify dry eye as aqueous deficient or evaporative, and it's important to try to find out the risk factors and the cause of disease. But quite often there is an overlap between aqueous deficiency and evaporative dry eye, so it's important to treat the patient in a more holistic manner. Examination can present as almost normal picture, or we may have severe staining in the cornea in many patients. But it's also very important to examine the lid and the conjunctiva as well. The lids, we know, the meibomian gland disease is very, very common in our patients, and it's very important to be sensitive about it and look out for it and treat it before cataract surgery. And we can also use diagnostic equipment to evaluate dry eye. Diagnostic scans are available, and we can also simply look at the autorefractometer, invert the lid on an autorefractometer, and use that infrared rays to see the pattern of the meibomian glands, to see how stressed they are. If there is dropout, in which case we know that the patient is going to continue to have chronic dry eye in spite of treatment. And it is also important to look out for lid parallel conjunctival folds or lip cough, or also, like we know, conjunctivochalasis. So this also is a reason for chronic dry eye, which the patient must be sensitized to before surgery. And it's important to check the status of the aqueous, and we can always use stains to help us make a better diagnosis. Fluorescein stain to look for tear film breakup time, or lissamine green and rose bengal to look for devitalized tissue. So we know that tear film breakup time is a very important indicator of the hallmark of dry eye. We've all done it, to evaluate dry eye. But now there are even non-invasive ways of testing for the tear film breakup time. OSA is one scan which can give us the tear film breakup time without having to stain the patient. And now there are a lot of equipment available to evaluate dry eye, because all of us are becoming more sensitive to this as a disease. We know that a healthy tear is not just aqueous, it's a complex mixture. It has antimicrobial proteins, growth factors, and cytokines. And we also know that altered tear film can definitely cause a lot of discomfort for us. There are ways to evaluate dry eye. It has been classified, and there are treatments available which are advised to us in a stepwise manner. We can always go back and refer to the dry eye workshop, and it's available for free online. But most importantly, we must know that there is no ideal tear film, ideal lubricant at this point. We have not been able to, simulate nature at all. So it's very important for us to choose lubricants depending on the patient's discomfort. And anytime we use an eye drop, a preservative-free eye drop is always better. Cyclosporin is an important drug in the armamentarium of treatment of dry eye, and it can really help in mild to moderate conditions. And it's very important to make sure the patient is doing lid compress, or treat meibomian gland disease with more than lid compress, either with LipiFlow or with intense regulated pulse light, which can help a certain group of patients who are not resistant to meibomian gland disease treatment. And then, of course, we have supplements like omega-3 fatty acids and oral tetracycline, lid scrub, and so on. So just to wind up, I think it's very important for us to be sensitive of dry eye in cataract surgery, before and after cataract surgery. And even if we are not sensitive to it, our patients will make sure they sensitize us to it, because they're so persistent in their complaints. And this is where I work. This is Coorg. All of you are most welcome to come and visit us in Coorg. Thank you.
Thank you, Dr. Samya. So now I'll request Dr. Srini Edakol to talk on modification of glaucoma medications for phacoemulsification.
Thank you, sir. Good afternoon, all. So when you are actually talking about initiation or modification of glaucoma medications for cataract surgery, these are the scenarios to be considered. Lens-induced glaucoma, postoperative glaucoma, ocular hypertensive or pseudoosculation patients who are not on any anti-glaucoma medication, glaucoma patients well controlled on topical anti-glaucoma medications. The non-glaucoma patients, including high hypermetropes, those with crowded anterior chamber, hard cataracts, those with poor endothelial status, also we have to consider. In lens-induced glaucoma, obviously the treatment is cataract surgery, but till the patient is taken up for cataract surgery, you have to give maximal medical therapy to control the intraocular pressure. And since prostaglandin analog, because there is an inflammation component here, so since prostaglandin analogs take a bit longer to act and it can induce inflammation, it may be avoided in these cases. Similarly, in postoperative glaucoma, it might be a good idea to prostaglandin analogs, avoid prostaglandin analogs if it is possible. Coming to pseudoexfoliation, this study by Ken Hayashi et al. Have shown that oral acetazolamide administered 1 hour preoperatively and 3 hours postoperatively blunts that postoperative intraocular pressure spikes that happens after cataract surgery in pseudoexfoliation patients. So this is good and can, like carbonic anhydrase inhibitors, see it's supposed to act on the ion transport, but can it be used perioperatively in cataract surgery? This study has shown that carbonic anhydrase facilitates ion transport impacting corneal endothelial function in bovine, but not human corneal endothelium. So this finding supports the clinical observation of no corneal swelling in humans administered with the carbonic anhydrase inhibitors and suggests that an alternative ion transport mechanism may be operational in corneal endothelium in different species. So carbonic anhydrase inhibitors may be safely used. So those coming to those with hard cataract and poor endothelial status. So what anti-glaucoma medications to be used? These are anti-glaucoma medications, but it's been shown that ROCK inhibitor, repasodil, shows an endothelial protective effect. Okay, so this study was done in two groups, 13 glaucoma patients and 13 controlled. It was seen that the mean rate of increase in the thinnest corneal thickness 1 week after cataract surgery was 1.25% in repasodil group, which is significantly lower than the 5.97% increase observed in the control group. So the result suggests that repasodil may help maintain the corneal endothelial function integrity and reduce cell loss after cataract surgery in patients with low corneal endothelial sensitivity, suggesting that it may be more broadly used for protection of corneal endothelium after cataract surgery. But when you're using these ROCK inhibitors, you have to consider this corneal honeycombing. So this is corneal honeycombing that happened with ROCK inhibitor. But the good thing about it is that it doesn't seem to affect vision and it disappears after stopping ROCK inhibitors. So small eyes, use of 100 ml 20% mannitol given half an hour to 1 hour prior to surgery effectively lowers intraocular pressure and increases anterior chamber depth. So it will be a good idea to give mannitol in these cases. So let's come to the other part. The effect of cataract surgery on eyes with glaucoma. We have to consider cystoid macular edema and the effect of cataract surgery on intraocular pressure. First, let's consider cystoid macular edema. It's been seen that cystoid macular edema is significantly greater in patients with primary open-angle glaucoma, and their risk is higher in patients using prostaglandin analogs. So this is the mechanism in which the cystoid macular edema occurs following cataract surgery. The surgical stress releases inflammatory mediators, transvitreally it goes and breaks the blood-retinal barrier and causes cystoid macular edema. But it is highly unlikely that these prostaglandin analogs directly influence the normal blood-aqueous barrier function. Rather, they may prolong the production of endogenous pro-inflammatory mediators produced by the lens epithelial cells after cataract surgery. But as you know, a lot of studies have shown that prostaglandin analogs can play a role in development of pseudophakic CME. So should we stop prostaglandin analogs after cataract surgery, for cataract surgery? See, all of your wonderful phacosurgeons, absolutely, and the modern phacoemulsification doesn't cause release of huge amount of prostaglandins. So should you actually stop? But another point is there. See, if you stop prostaglandin analogs and IOP increases, the untreated elevated intraocular pressure itself is a risk factor for cystoid macular edema. So there has to be a balance. But consider, like we have decided to stop prostaglandin analogs. When do we stop it and with what do we switch? See, pilocarpine is effective, acts very fast, but obviously it can't be used. Topical carbonic anhydrase, it's also very, very fast, but it's not strong enough to replace prostaglandin analogs. All others takes about 4 weeks. So if at all a switch is made, it has to be made 1 month before cataract surgery. Use brimonidine, it causes allergy. You want a quiet eye after cataract surgery. Timolol, you have to consider the systemic implications. And another factor is to be considered. See, how long, see, stop prostaglandin analogs, how long is it going to stay back in the eye for it not to cause effect? It's been seen that the effect of prostaglandin analogs lasts about 4 weeks after stopping it. So based on this, prostaglandin analogs should be stopped 1 month before surgery. But this washout is for the IOP lowering effect because of the remodeling that occurs in the ciliary muscles. And there is no direct evidence of prostaglandin analog persistence in eyes for a month with CME inducing effect. But still, it might be a good idea to wait 1 month if you're stopping prostaglandin analogs. There is another study which has shown that there is no statistically significant increase in risk of clinically significant macular edema with prostaglandin analogs. But this survey report has shown that it might be good to stop prostaglandin analogs because there is an increased risk of cystoid macular edema. So should we stop prostaglandin analog? Yes, if you're sure that you can control IOP with alternative anti-glaucoma medication. Yes, if you can wait 1 month for cataract surgery. Yes, if the patient is at higher risk of CME. So stop prostaglandin analog postoperatively in complicated cataract surgery. So effect on IOP, it's shown that cataract surgery itself lowers the IOP for about 4 millimeter and its effect lasts longer. And the strongest predictor is a preoperative and higher intraocular pressure, the higher the drop. And studies have shown that you can reduce the anti-glaucoma medications. So can we drop it, reduce the anti-glaucoma medications? Yes, but it should be based on the level of postoperative IOP. So conclude, the perioperative intraocular pressure control is critical importance. Though IOP may drop post-cataract surgery, one should reduce anti-glaucoma medications postoperatively only after proper evaluation. Topical prostaglandin analogs, if the patient is at a higher risk of cystoid macular edema, stop it. ROCK inhibitors may be used for endothelial protection. Topical carbon kinase inhibitors can be used. And welcome you all to AIOC Kochi 2023. So please come. Thank you.
Thanks, Dr. Sridhi, for your excellent talk on what to do in those cases. Now I request Dr. Ramamurthy sir to deliver his talk on phaco in hard cataracts.
Thank you. Mine is going to be essentially a video-based presentation. Pearls for phaco in hard cataract. Let's just run through these videos. All of them are on 2x speed. So there might be a little abrupt movements. As you can see over here, the video is not running here. So as you can see over here, it's a fairly hard cataract, and it's always a good idea to stain these capsules because that gives you a better visibility. It's important that the size of the incision is quite adequate. Usually I aim at about a 2 millimeter incision. 2.2 millimeters the width of the incision, so it's almost a rectangular incision. Extremely important to get an adequate rhexis, as you can see over here, because if you have a baby rhexis, then the interlenticular pressure is quite high. If you don't spin, you don't win. So it's important that a good hydrodissection is paramount importance. Rotate the nucleus quite adequately. I always remove all the cortical matter and whatever little epinucleus is there. Create a small trench over there, which gives me an excellent access to the center of the nucleus. And then right through this, I'm using only the longitudinal phaco because I believe that this gives me an excellent boreal of the phaco tip into the hard meat of the nucleus. Once you do that with a chopper which is about 1.25 millimeters in length, get into the depth of the nucleus and then approximate the chopper as well as the phaco tip to each other. At the same time, there's a little amount of lateral separation. As you can, the number of quadrants that you make is directly proportional to the hardness of the nucleus. Usually I make 4 quadrants, but in a relatively hard cataract like this, I make 6 or sometimes even 8 quadrants. And this is the time I inject a little bit of dispersive viscoelastic to coat the endothelium and subsequently inject a HPMC in the middle so that most of the phaco action happens in a lake of HPMC and there's no raise as far as there's no chances of a wound burn from occurring. Let's look at a similar situation. I'll be trying to emphasize different aspects. There's always a little bit of intracameral xylocaine that's injected. Again, the size of the rhexis is extremely important. Usually I aim at about a 5.5 to 5.7 millimeters, a good hydrodissection. And as I mentioned earlier, it's important that you use so in this stage, I use only HPMC because all the division is going to happen within the capsular bag, and I'm not really concerned about the injury to the endothelium. And as you can see, a small trench is made, and then subsequently I bury my phaco tip, which is exposed to a length of about 1 to 1.25 millimeters. And it's not a horizontal chop or a vertical chop, it's rather a combination of both, where you remain within the confines of the rexus. And that's the reason that I want to stain each and every one of my rexus. And I bury at the edge of the rexus at 6 o'clock position, and my tip is at around the middle of the nucleus, and basically the second hand, the left hand, which moves to the tip. And as this movement occurs, I also there's a certain amount of lateral separation. The lateral separation should not be too intense, because that itself can impose a significant amount of stress on these zonules, which are often compromised in these cases of hard nucleus. That's essentially the dispersive viscoelastic which is going in, but at the same time, that's essentially to coat the new endothelium. Subsequently, I inject some HPMC in the center, because just the dispersive viscoelastic, if you activate phaco in the center with the dispersive viscoelastic, sometimes this is the only situation where you can get a wound burn. Again, if it's a fairly hard nucleus, it's always a good idea, once one heminucleus is out, go ahead and repeat the maneuver, inject, coat with dispersive viscoelastic, then inject a certain amount of HPMC in the center. You can use a heel-on, but I think that's a waste of money. You can, even a HPMC will serve the job very well. As you can see, my tip is laterally directed, and the phaco, the nucleus fragment just appear to be flowing in. And this is just the routine steps of this wound-assisted intraocular lens implantation that is occurring. And I think that it works very well in most of the cases. And this is essentially a multifocal intraocular lens that was implanted. This is an eye which has been pre-treated with the laser, but the essential steps essentially remain the same. But the fact that this has been chopped into small fragments about 200 microns each, it helps me to reduce the phaco time almost to half. But the basic principles, as I emphasized, was the same. Again, create a small trench, then large rexus. Usually I aim at a 5.5 millimeter rexus, and then bury the tip into the nucleus fragment, approximate the two, and usually what you get is a nice chop. And as you can see here, I often feel that the laser as well as the phaco are complementary technologies and not competitive technologies. Once you appropriately use the two, you are able to enjoy the benefits of both. The basic principles of phaco emulsification is of paramount importance, and you observe each and every one of them. It's not that you don't get a bad cornea just because you have used a laser. So dispersive viscoelastic to coat the endothelium, HPMC in the center, and go ahead and refill. Almost every 5 seconds of phaco time, I go ahead and refill, recoat my endothelium. I find that at least in my hands, it results in a very nice clear cornea and postoperative day one. That was again injection of the intraocular lens, wound assisted. Just because we are comfortable with the direct chop, it doesn't mean that you can't do with a stop and chop. I find that this is a rescue technique. It works wonderfully well. Create a deep trench and ensure that I use 2 Sinskey hooks through the 2 side ports. Go into the depth of that trench that you have created and separate them gently so that you have 2 heminucleus. As far as you have broken the backbone of the nucleus and there are 2 distinct quadrants, then your job is well done. Just a few quick take-home pearls. Choice of anesthesia, I often do under local anesthesia, but topical anesthesia, but I feel that it's going to be a challenging case. Peribulbar is the way I go. Secure incision, both the side ports as well as the central incision, especially of 2 millimeters. Make sure there's no leakage of the incision. 5.5 millimeter well-centered rexus, hydrodissection and a good rotation. If it's a direct chop, a mini trench helps. If it's stop and chop, deep trench and getting into the center. Breaking the backbone of the nucleus into 2 levels is important. Multi-level chopping, gentle lateral separation, and as far as possible, iris plane or posterior plane phacoemulsification, using dispersive viscoelastic to coat the endothelium, and then beware of weak zonules and capsule, which is often concomitant with a hard nucleus, so that all your maneuvers have to be as gentle as possible. Thank you so much for your attention.
Thank you, Dr. Ramamurthy, for the lovely demonstration of the phaco in hard cataracts. Now I'll request Dr. Nagendra Prasad to talk on phacoemulsification in posterior polar cataract.
Thank you, sir. Respected chairperson, my dear colleagues. My topic is phacoemulsification in posterior capsular cataract. This is my way. There are various surgeon adopts various techniques. So I have doing this technique regularly. First, come to know why it is important to consider separately. There is a strong adherence of obesity to the weak posterior capsule, and there is a 26% likelihood of defective posterior capsule perioperatively. There is a high rate of intraoperative posterior capsular defect up to 0 to 40%. So, general feature lies that it is congenital in nature most of the time, and is dominantly inherited disorder with variable expressivity, but can be sporadic, and there is a positive family history in 40 to 55% of cases, and it is almost bilateral in 65 to 80% of cases. There is no sex predilection, and incidence is 3 to 5 in per 1,000 live births. So these are the overall features. This is a classical picture of the disquiet separate opacity and onion pill-like appearance of the posterior capsular cataract. You have to differentiate between the posterior capsular cataract and polar cataract by seeing this nature. And if you are having this type of disquiet opacity with extension into the posterior surface, posterior side of this opacity, then there is a chances of having posterior capsular rupture. So this is the biggest challenge to how to tackle the posterior capsule, how to prevent the posterior capsular rupture for the safe surgery. And if you are again, there is a very advanced posterior polar cataract, and if you come with this, that it is already occurred with the nuclear sclerosis, and so how to get an idea about the whether there is a posterior capsular rupture is not they are not operatively. There is, you can have a bit, little idea about the Master 700. You can see this picture. If this is highly effective from the plaque, with appears separate from the capsule. Here you can see here, so there is a chances of there is no PC defect operatively, but nevertheless you don't have to fiddle with the posterior capsule, because in those posterior polar, and even in posterior capsular subcapsular cataract, the PCs are very thin, and you don't have to rub it for the sake of clearing any residual materials. So this is another case. But if you see the here you can see the, so there is a opacity, and this is adherent to the posterior capsule. So in those cases, you have to have very cautious for while doing the phacosurgery in those cases. So far as a consideration is surgical techniques is concerned, so anesthesia preferably should be under the perivalvular block, and construction should be like that. If you want to convert, you can easily convert. So more over towards the corneal side. And so far as phaco-parameters are concerned, you just reduce your phaco-parameters, and so far as capsular axis is concerned, so actually there is a consensus about making a smaller axis for if anything happens, you can capture the optic into the anterior capsule. So, but in my opinion, I made slightly better, larger capsular axis, because there is a fluid build up into the capsular bag, might rupture posterior capsule in those cases, as Dr. Ramamurthy has just shown. So far as hydro procedure, hydro dissection is not recommended in those cases, but hydro delineation is recommended, and you can have multiple small fluid injection. So the fluid does not go beyond the posterior capsule. So 3/4 quadrant you can always do hydro dissection. So far as nucleotomy is concerned, you don't have to chop multiple chopping. Try to remove the nucleus as in toto as much as possible. So if in case of anything happening, the loose materials doesn't fall into the posterior vitreous cavity. This is a small video I just show here. You can use for the capsular axis, you can use the Callisto marker or markerless cataract, or you can use just metal marker on the cornea to guide the capsular axis. So I just here I can show you. I am making the axis here, and injection into the hydrogel, don't rotate, try to rotate, just slight feeding of the nucleus is much more here, important here. Here I performed the successfully performed the phaco surgery. And but what happens? While I was doing removing the cortex, I just saw there is some opacity onto the capsular capsule. I tried to fiddle it, then just see what happens. There is a rupture of the posterior capsule. So these are the very weak capsule. You don't have to rupture. I don't have to rub the opacity. But somehow I managed to do, because this is a case of a toric case. So I implanted inside the bag. So there is another case. Just a little bit. Here you can. Yeah, just. Here I can show this after Raxis, I just inject the 3-4 quadrants, like just, yeah, you just inject, hydrodissect, and don't inject much, so the fluid doesn't go beyond the posterior opacity. So 2-3 quadrant would be sufficient, and so far as if you have to remove the nucleus, it should be, I'm not going to rotate, and it should be, just don't make multiple pieces here, and use your blunt chopper to bring the nucleus pieces towards the phaco tip, and that way you can safely and effectively consume it. Like, don't multiple chopper, do multiple chop. Because most of the cases, these are the soft cataracts. Thank you for your patience hearing.
Thank you, Nagendra. The next speaker is Dr. Madhusekhar. He'll be talking on cataract surgery in colobomatous eye.
You want to present? You want? I will. Okay. Good afternoon, everyone. I am going to present on cataract surgery in colobomatous eye. As you all know, these are the challenging cases we all encountered during cataract surgery. So I have no financial interest to disclose. What is coloboma? Coloboma comes from Greek word curtailed, means it ends before completion. It is a defective closure of embryonic fissure. Usually closure of embryonic fissure occur during 7th week of pregnancy. It may be unilateral or bilateral, and it most commonly in infranasal quadrant. What are the surgical difficulties while operating these eyes? Usually there will be associated macrocornea, crowding of anterior chamber. Most of the cases present late with advanced cataract. People will be small, slightly eccentric. Chances of rhexis extension will be there. Posterior capsule rupture and gonodialysis will be there. So I will just want to show the challenges. Like this case, you can see that rhexis is going on fine. After completion of rhexis, gentle hydrodissection was done opposite to the area of coloboma, but during hydrodissection, rhexis gave way. So I thought that a very small extension is there, so I tried with phaco, but it started tilting. Then I have to convert, changing the site from temporal to superior, and it was converted into a small incision cataract surgery. Second case, second eye of the same patient, cataract was more advanced, so I planned for seeing the complication in the first eye. I planned for a small incision cataract surgery in other eye. in this case also, rhexis was meticulously done. It started with capsulorhexis forceps and completed in the area of colobomatous area. Slightly brownish cataract. So gentle hydrodissection was done and bimanual prolapse of nucleus was done. But you can see that just after nucleus prolapse, rhexis extended in the area of colobomatous area. This is the third case where everything cortex was, nucleus emulsification was done, and then I was planning to place IOL, and then you can see that rhexis torn away in the area of colobomatous area. So how to overcome these challenges? So in colobomatous eye, use iris hook to expose the non-colobomatous area. And rhexis will be slightly difficult due to general compromise and fibrous capsule near colobomatous area. It is important to tailor the rhexis, that is smaller in the site of coloboma and larger away from it. Like this is video, you can see that in this case, actually means pupil is large enough to do phaco, but in this case I exposed it more towards the non-colobomatous area so that I can decenter my rhexis away from the colobomatous area. You can make larger rhexis in the area away from coloboma. Phacoemulsification was done, and then it went on without any extension of capsulorhexis. After cortex was, lens was placed in this case. Sometimes you can see that sometimes that there will be very small people, or it may require some means optical or iridectomy also. Sometimes this cosmetically you can give, you can repair the pupil also doing pupilloplasty. So this case you can, after completion of surgery, you can try to suture the pupillary margin near the colobomatous area, passing a 9-0 Prorin suture from one end of iris pupillary margin to other end, and then you can externalize it through side port, or you can do Amar Agarwal's technique like single pass 4-through technique also. Suture is externalized through side port, and then you can secure the knots with 4 to 5 knots, so that you can get round circular pupil in post-op. So sometimes, most of the time, you can encounter with advanced cataract. So MICS is preferred over this type of cataract. Temporal site is preferable because you can get better exposure area and you can avoid stress on the journal dialysis area. And larger sclerocorneal tunnel because cataract will be slightly on harder side. So in this case, I am going through temporal tunnel, meticulously done tunnel, and you can make slightly larger pockets because cataract will be slightly on a harder side. In this case also, you try to better to stain the capsule because visibility will be not very clear in this type of cases. And you can, in this case also, you can expose the non-colobomatous area using iris hooks so that you can make larger rhexis away from the colobomatous area. Bimanual technique is used to prolapse the nucleus. And you can place 3-piece IOL orienting the haptic towards the colobomatous area. So this is our publication in JCRS in 2020, in which we have concluded that manual small incision cataract surgery is an alternative to phacoemulsification in colobomatous eye with advanced cataract. So take-home message, cataract surgery should be planned earlier in colobomatous eye, rexis should be tailored, and that should be smaller in the site of coloboma and larger away from it, gentle hydrodissection, and MICS is better alternative in advanced cataract. Thank you.
Thank you, Dr. Madhusekar. Now I'll call upon Dr. Samresh Srivastava, who is going to talk on expanding the horizons in toric IOLs.
I'd like to thank the AIOC for inviting me for this talk on expanding the horizons of astigmatism with toric IOLs in our practice. Now, toric IOLs have been there. All of us have probably used it at some point in our lives, and some of us are using it routinely. And it's an extremely successful tool, probably one of the best lenses that has ever come into the market. But we want to understand whether we can extend this comfort of toric IOLs and the advantages in eyes which have certain pathologies. Let's start with pterygium. Now, pterygium is so common in our part of the world, and particularly pterygiums which, when they turn up, are atrophic. Pterygiums that are atrophic do cause temporal drag of the cornea, and they cause a very typical and a very irregular sort of an astigmatic profile, which is called typically a coma. And a coma is a bad aberration because a coma is not correctable with anything. No spectacles, no IOLs can correct coma. And this is not a suitable candidate for a toric IOL because the basic prerequisite is to operate in a regular astigmatism. But what happens when you do a pterygium removal in your clinic? If done well, and if it done in the right plane, notice how the entire coma vanished away into a regular astigmatism, because the cornea that was pulled on one side has now been left and it's become fully round and regular again. Just to show you pre on the left side and post pterygium excision on the right side, and how an irregular cornea turns into a regular cornea. Now, this patient does have a good astigmatism profile, and so we counsel this patient that they will need a toric IOL, understanding the fact that they might have surface symptoms secondary to pterygium removal, and they may be on, and we counsel them to be on lubricating eye drops for an extended period of 2 months. And needless to say, the patient was very happy, unaided 6/9, which is something we otherwise would have not promised the patient and been wary of, considering the pterygium and the irregular astigmatism. But then there are more challenging cases. There's the refractive surgery eyes. And I've never seen an RK happen, but I see a lot of post-RK patients that come up in our belt. And these patients are not all of them are bad. In fact, some of them are good. Some of them are astigmatic, but regularly so. And with this patient, I wanted to understand what we learned, in our clinics, was the fact that what we're treating is just the pupillary cornea. We don't treat the whole cornea when we operate with the cataract. Only the part where the light goes through to cause that refractive correction is what we treat. So if the patient is regular in the pupillary area in his astigmatic profile, I think it's a good candidate to put a toric IOL, because the rest of the cornea does not matter. We did counsel this patient of surface symptoms because RK incisions can split open at any point in time, particularly with higher IOP surgeries. And we did tell them that there is no guarantee of distance spectacle freedom, because no matter what IOL calculation formulas, you can still go wrong. And the fact that there may be some optimal. We use the IOL calculator that's available at the ASCRS for free, so all of us can use it for all refractive surgery, post-refractive surgery eyes. When we looked at this patient at the 3-week follow-up, unaided distance was 6/9 parts, which is very good considering the fact that it was a previous RKI and reaching target is difficult in the first place. So we were able to hit target with the biometry, the calculation, and the astigmatism profile, and all the patient landed up was a -0.5 diopters. The best thing about RK patient is one RK patient sends the second RK patient because they all have a cohort and they all talk and what they did right or wrong in life. This is just to show you how the lens looks well centered and stable. All these patients in our clinic are counseled for suturing these incisions because time and again they can open up. And this is how the IOL looks well centered. The more sinister problems are retina and glaucoma. And this is a gray zone, whether we can put a toric IOL in a glaucoma eye or whether we can put a toric IOL in a glaucoma operated eye. And this is just, again, a patient, 46-year-old, open angle glaucomas with had trabeculectomy is done. And after a year of trabeculectomy, had a secondary cataract for which she had to undergo cataract surgery. This is the profile of the patient, 1.6 diopters of regular corneal astigmatism, as can be seen on the trace view over here. And just to show you in a larger perspective, the IOP is well controlled, and this is a bad field. The superior arcuate part is almost gone. The inferior one's already building up. And the question is it right to do this IOL in this patient, or is it not right to do this IOL? Macula is okay, so the OCT is unremarkable. But we did counsel the patient of suboptimal vision. And with the 1.5 diopters of astigmatism, with a glaucoma and a field that's like that, the contrast is already down. And if you have to wear spectacles, you are going to drop the contrast by an additional 10% or more, considering you have another frame in front of the eye. And so we counsel the patient that they need a toric IOL. And so with this, they can enjoy whatever best corrected vision they have without depending on glasses. 6 months, patient is good. Unaided visual acuity is 612, partly related to the glaucomatous optic atrophy. The patient does not accept any refractive correction because there is none to give to the patient for distance correction. And the patient is happy. And so I guess with these, this is how the patient looks. It's an old trap with a large PI. And you can see the toric IOL sitting well. I mean, you have to understand that the PI has to be covered by the lid margin. And with that, this thing I think is probably one of the advantages of a toric IOL, that it's just a monofocal lens with an added astigmatic profile. And if you can take off that much handicap from the patient's eyes, particularly in diseased eyes, I think there is no harm in putting these lenses in these patients. And I think in our hands, it has worked out very beautifully for these eyes. So a take-home message for glaucoma is it can be considered. I mean, you have to look at it clinically, you have to be a good clinician and understand the pros and cons. So even for ARMDs, early AMDs, and early diabetic edemas, diabetic retinal changes, I do prescribe toric IOLs to these patients. And to come up with the pediatric eyes. Now this is again a gray zone of whether we should use toric IOLs or not. And a lot of literature has been published over the years that suggests that the cornea, the curvature of pediatric cornea tends to stabilize by 3 to 5 years of age. And you only change when you're old because your collagen breaks down and you go from with the rule to against the rule astigmatic profile. In children, needless to say, you have to combine it with the posterior capsular excess, and you have to follow up these patients to rule out any visual axis obscuration. And just to show you how the patient looks 6 months and 6 years at follow-up, and we have a long-term follow-up of these patients with pediatric toric, and they do very well. And it's also important because pediatric, if you treat astigmatism, the chances of amblyopia and visual rehabilitation is faster. Just to end up, sometimes you get cataracts, which are very interesting. So this is a patient who came up to me with an air blower that hit his eye. And at 3 weeks, this is what it looks like. The posterior capsule is split up open, and there's a cortical cataract in a young patient developing, like so. We decided to do a femtodelineation, just like we would do in a polar cataract. So we use femtosecond laser in this to create a rhexis and to create rings so that we don't have to do any hydro maneuvers inside the eye. And I'm just going to move out of this because it's not the purpose of the talk. But once you make rings, it's easier to debulk the nucleus. And once you debulk the nucleus and use moderate parameters, particularly in eyes where you're able to preserve that PCR and not enlarge it and maintain the integrity of that PCR, you can put a toric IOL considering your bag is stable. So in this patient, considering that the anterior vitreous phase was not ruptured, because we used the right parameters, we went slow. And more importantly, the PCR margins were round and fibrosed in 3 weeks. So we had a hope that the PCR does not split. We were able to place the lens very comfortably, as you can see, inside the capsular bag. And once the lens settled down inside the capsular bag, and your part is done, you know this lens is not going to move, and a bag is a natural compartmentalization for the lens in any case. And so it can be considered if you have traumas that have ruptures of the anterior or posterior capsule, provided you realize that there has to be a 360-degree cover and there has to be no sharp edge. And with that, I'd like to end the talk. That in our clinics, now that we have used toric IOLs for so many years, I think we can expand the ideas, we can expand our horizons, and look at that one odd patient that can do well with the toric lens compared to a monofocal. Thank you.
Yeah, thank you, Dr. Samresh. So I think I'll not delay any further because already we have delayed the next session. So we end up the session here. Unfortunately, there is no time left for any discussion.